Welcome to Reimagine Healthcare, the show where we take a hard look at the future of Canadian healthcare by featuring inspiring doctors and leaders who are shaping it. Our guest today is Dr. Julie Wilson, a family physician and the founder of Terra Nova Medical Clinics. Terra Nova is a large network of primary care clinics based in BC. Dr. Wilson, welcome and thank you so much for joining us today.
Well, thank you so much for having me. It's my pleasure.
Awesome. We are very happy to have you here on the call. And to start, maybe if you can take us back to the beginning and what drew Dr. Wilson into family medicine in the first place?
So I'm the first person in my family to go into medicine, and a family doctor was the only kind of doctor I'd ever seen before. So that was just my view of what a doctor was. So when I got into medical school, I really wanted, of course, I went in because I really wanted to be a doctor, but I didn't actually know that much about the different specialties. I took a look, through my different rotations by meeting other people about everything, but I was always drawn back to that generalist medicine and the fact that you get to have the long relationships with people that I feel make medicine really worthwhile for me, where you get to really know someone, know their family, know their preferences and their personality. And for me, it's a joy to see my patients after all these years. It's really just like a reunion every day.
Awesome. And was there a moment in your career that reaffirmed this reason behind your choice?
Um, I have gone through quite a bit of career change over the past few years, and it's not something that I'd previously expected. Of course, we all have this vision of medicine, and if you've never been in it before, you don't really know what it's like to be there. So there are a lot of things that I've adjusted, but since the pandemic, I really got more into business and medicine together. I previously did have my own clinic. I always wanted to have my own clinic, but at the time it wasn't that unusual for every family doctor to have their own clinic. It was becoming a little bit more difficult because of rising costs, but it was still quite typical in British Columbia for solo practitioners to give their practice to another clinician and then they would have a solo practice, or alternatively to work as a walk-in physician.
I understand. And that brings me to my next question or topic here is uh, you've built a reputation not only as a clinician, but also as a leader, shaping a new primary care model for clinics in BC, particularly through your work building Terra Nova into a large network of clinics. So can you tell us more about what Terra Nova has become today, maybe in numbers?
Yeah, so when we first started, it was myself and my husband, two family doctors. And then over time, we added, 2015, 2016, another family doctor, maybe another locum family doctor, a dermatologist, a rheumatologist, etc. But now we are over 100 clinicians, perhaps over 110 now, and we have another 100 coming in the next year. We've really expanded. And the impetus for that, for me, was seeing the healthcare system during and after the pandemic. For me, it was extremely upsetting. I don't think of myself as a perfectionist, but I always will work harder to try and improve a situation if I don't like the way it is. And I think the pandemic just set something off inside of me where I thought, I just can't continue like this. Society cannot continue like this. And I'll just keep doing what I can, one foot in front of the other, and until this problem is fixed. And maybe there'll be lots of us doing it. I think there are a lot of people working on it, but in the outpatient environment, it's very difficult because of so many factors. There didn't turn out to be that many other clinicians like myself who took the same journey at the same time, leading us to now become the biggest in British Columbia.
Awesome. So basically, you've been upset about a certain reality that said, well, Dr. Wilson, instead of doing it on an individual basis, let's do it as an owner and as a leader. And
Yes.
today, if I'm not mistaken, you're more than 30, 40 clinics, Terra Nova, across.
Well, we're about 2025, but we have many planned over the next few years. We are completely funded on our own without private equity or outside business investors on purpose so that we can focus entirely on what we as clinicians believe needs to be done
And
without, yeah. Sorry.
that's really huge. And
Yeah.
so what motivated you? What motivated to say, like, not only being a physician, but also, and not only like managing clinic or owning a clinic, it's owning multiple clinic across a huge territory. So what was the inflection point and the real driving force behind this idea?
So I did my residency in Ontario, which has a different system than British Columbia. British Columbia, you can think of medicine in the 80s. Solo practice, the super doc, everybody maybe rounded on their own patients in the morning, delivered their own babies. That's how it was when I was young and when I started going to medical school. Before I started practicing, it started to change. But when I went to Ontario, I saw they had these big health groups, 30 to 50 people, allied health. And then it made me think, well, what's happening in the rest of the world? You see, not that we should follow American healthcare per se, but there might be Kaiser Permanente with 4,000 family doctors working together, or big groups across Australia where they're able to communicate together. The very siloed practice in British Columbia was going to go away. It's gone away pretty much everywhere else. And I just looked around the world and saw this must be the future. And you can see why. If you're a solo practitioner, you have ultimate autonomy. But one of the things you don't have is flexibility. You have no cushion for extra costs. You have no vacation. You have no sick time. You're always there, like an old-fashioned country doctor. And the new generation wasn't going to put up with that. So I got the idea that we needed to build something modern, or the system in British Columbia was going to crumble further. It wasn't modernized to the modern workforce and also to the modern patient. It just needed to be changed. So a lot of people here ask me, where do you get these great ideas? How did you think of that? I'm like, it's all out there, guys. Like that, not one of these things is an original idea. I just brought it here.
It's really impressive, Dr. Wilson. And by the way, when I visited some of your clinic, I felt a different vibe. Like not only from the aesthetic, and you just come in and you see a lot of light and good reception and a bit of green. Also, the people were smiling and was a lot full of energy. How you're building that? Like, what is the secret sauce behind this positive vibe and this energy that your people inside these clinics are driving?
Yeah, I tell them very frankly why we are here. We're here because I am upset at the medical system, not for anyone's fault, right? It just happened. And we are here to do a good job for society. But how do we do that? We are going to take care of each other. So there's only one rule in the clinics, really, is that everyone all the time needs to be treated well with respect and kindness and compassion. And all feedback is good feedback. There is nothing that happens in the clinic that I don't want to know about, because either there's a misunderstanding there, or there's a system problem, or something that we can improve. Times are changing so quickly that if you're not looking for pretty much daily feedback, you're always going to be behind the times. And I think when people feel heard and then they feel respected, they pass that on. And I maintain that throughout the entire management structure. I tell people constantly, there's no one who cannot reach out to me directly. But of course, they should still reach out to their, in the command structure. But that, I think, is the reason that we have a good culture. We also spend a lot of time and energy making sure, even though it might not be financially the best choice for us, to make it a qualitatively nice place to work, unlimited food and drink for everyone, events together. We have a Discord chat group. We put up pictures. We, give them maternity leave, paternity leave, extended medical, dental. We actually didn't even need to do that for retention. I just did it because I felt like it was the right thing to do. In the pandemic, when there was this time period, the government said they would give everyone pandemic pay as a secretary. Then they rescinded it very quickly for the outpatient departments. And it was so disappointing for all the outpatient staff. That's when a lot of clinics ended up closing. They were so disappointed. I paid that out of my own pocket. It's not a big deal to me. As I think that money is very nice, but it's more nice to have people feel respected.
Very inspiring. And how do you personally define success at Terra Nova? Like, is there any key metrics or North Stars that you use to measure and track that success?
There are a few things. So one would be, I like to do the Great Place to Work survey every year and see that people think it's a great place to work. And if not, then we fix all the things in their comments. So that is one thing for success for me. Another is how big our patient panel grows. There are hundreds of thousands of people in British Columbia without a family doctor. And then you still have a lot of people who may have a family doctor, but it's not the right fit for them. They no longer live in the same city as them. All of these other problems. Plus, don't even get me started on the specialty wait times. If I can just fix that a little bit by moving forward, bringing on one more person might attach another 1,000 patients, et cetera, we can bridge that gap. So we have over 250,000 patients in our roster. I'd love to get to 500 or a million, just keep going until everyone has a doctor, and then actually they can start shopping for doctors. That would be nice, so you can find a good fit for yourself. And then another thing for success would be, I think, how many regions we can get into. So we have a lot of clinics in Vancouver,
Coverage.
Greater Vancouver, now Victoria area. But although there is a shortage everywhere, the more we grow, the more I'd like to be able to use our resources to expand into smaller areas where the situation is more dire.
Yeah. And this is a question I ask clinics and clinic leader a lot, and is not operating at a loss or being profitable at least. Is it a metric that Terra Nova looks at?
Yes, I would like to not operate at a loss. Obviously, growing quickly depends on how you qualify it. It costs money, but it's a real taboo in medicine. You should, in medicine, never ever talk about making profit in Canada. It's actually quite funny. When I started, a lot of people said a lot of, I mean, not really offensive, but interesting comments to me where they say, well, why are you doing this? Are you just trying to take money for other doctors? I said, well, I mean, if I'm managing other doctors, shouldn't I get paid for that? And they're like, no, I don't think so. The concept of making money in primary care or medicine is considered very negatively. But this also creates a problem because there's making money and there's having contingency, right? If you have anything go wrong, like you have a staff quit and you have to hire an emergency staff who costs more money, or if you have a doctor suddenly quit, or something floods and you need to change the floor, where does that money come from? It doesn't come from the doctors that pay you overhead, really. So what ends up happening is when these things happen, clinics close. They close all the time, and then people have to move, and then patients have to move, and the data has to move. And I think that this concept that there should be no profit or contingency or savings in the management or growth of a clinic is actually harming the system.
Yeah. By the way, I like me. I come from the business software world, and not being profitable, it means that you don't have the mean to do the right things. Like
Yes.
not being profitable, it means you cannot increase salaries to retain the best talent. It means that
Yes.
if you don't have the best talent, you can't do the best software. If you don't do the best software, it means the customer are struggling. And
Yes.
profit really trickles down into having the mean. And people associate profit to be able to buy maybe a Ferrari. But like most of the leaders, especially in the clinical spells that I know, they're struggling to just keep up and keep doing the right thing for the clinic and for their staff and for their physician. And
Totally. I totally agree. I mean, I've taken over a lot of clinics now. I visit a lot of clinics. I like to know what's going on. When I was young, people would come in, somebody would cut their hand, you would suture them up, you had an autoclave, you did IUDs, you did all of that. You did the pediatric vaccines. We are the only clinic in Richmond where I work that does pediatric vaccines because it's a money loser, right? So what happens is this shrinkflation in medicine, people stop doing things. Most clinics don't have autoclaves anymore. I've looked at clinics, they don't even have speculums. Can you imagine having a family medicine clinic without a speculum? So, when these clinics are able to run, I'm putting this in air quotes here, at a lower overhead, and doctors keep saying, oh, I want to pay less, I want to pay less, I want to take more home, my cost of living is going up. The costs are going even higher in the medical management space. And they say, sure, I'll cut your costs, but they're not realizing the services they're cutting, which then goes down the patient line. If you can't switch family doctors because there are no family doctors, and your family doctor's office does not have a speculum, then where are you getting seen? Nowhere, I guess. The emergency department. If they won't do sutures for you or a biopsy, then you end up on a 1-year wait list for dermatology because they can't afford a $5,000 machine and the staffing to do the daily spore testing and cleaning. Well, each emergency room visit is like $5,000. The costs just get pushed to someone else, and it always ends up being more costly. So if you were to give me like 20% more profit, for example, we would just have so many, we have all those services, but I would just have even more services. It would be easier to get through on the phone. We would have better technology. We would have longer hours. We would have more space. The rooms wouldn't be so tiny. There would be so much more happening. You're right. We wouldn't be buying Ferraris.
I'm sure about that. And it requires a lot of work and vision to be able to allocate those capital. And like, if I'm not mistaken, the clinic revenues are mostly is the rent that you charge for the doctor in exchange for the service and the space and the tools and the EMRs and everything that you do to provide those clinics. How a clinic that is auto funded like by private funds is competing with pharmacy affiliated clinics and subsidized clinics, like how you're competing that and how you're able still to recruit physicians to come work with you in such a
It's
setting.
really difficult. It's really difficult. And you see lots of clinics closing. I've talked to a lot of clinic owners who say, before the pandemic, they could put up an ad, locums.ca, and then get a locum, and then they would have people working. Locums.ca went out of business because there's no more locums. So you see a lot of these younger doctors moving towards these low overhead, low service clinics, but they take more home, they believe. And then there's alternate funding, right, through the prescriptions and referrals for other clinic groups. The way I manage it is this: a pharmacy's run clinic wants you to create prescriptions so they can make more money. A speculum does not give a prescription. An autoclave or a vaccine does not give them a prescription. What I provide is full service practice management. If something is not working for them, I will work on it. I don't have an ulterior motive there. I believe in full practice medicine. So I like to believe when I interview people, and I'm quite successful at interviewing, there's two types of people. There are the people who really just want to take as much money as they can and just take whatever trade-off happens for that. And that might be okay for them. But there are people who maybe had bad experiences in the past. They come from another country where they're used to having more support. They want to have full service types of medical practice. They have special interests. They need the equipment. They want to have a team. They want to have collaboration. Those are the people who prefer that full service model. Those are the people that I'm able to recruit. But that's because of our size and our economy of scale. If I were a small solo practice today, I don't really know what I could offer compared to a pharmacy-run clinic.
Yeah, tell us more about how scale is helping you right now. Like, having scale, what are the advantages or the benefits that comes with it?
Yeah, so we're able to just think of the classic clinic structure in British Columbia. You have an MOA, medical office assistant, or we call it secretary then, who would be your accountant, billing manager, receptionist, nurse,
HR.
HR, everything you can imagine, jack of all trades. And I think this probably worked in the olden days when everything was on paper. People physically came to the office, expectations were different, and you had people who would get a job and then stay in that job for 30, 40 years. Then they would develop the skills over time. It's not really the way you see the modern workforce working. So what we are able to offer is we do have an IT team, a billing team, an accounting team, a finance team, an HR team. So with economies of scale, we're able to have specialized and properly trained labor, which increases efficiency, but also you're able to get enterprise level deals, enterprise level EMR deals, phone deals. You can rent, sublet to people and get some income there during hours you're not using the office. These sorts of things help to subsidize the cost. With rent going up, it's hard to pay for rent, so we share rent, right? With scale, if you have one office and if you just have one or two doctors there, it's very hard to pay the rent. But if you have 4 or 5 doctors, you can pay the rent. So all of these things come together. In addition, I think that there are some soft benefits for scale, which speak to people. As I mentioned initially, people don't get vacation as a family doctor. You're legally supposed to be there for your patients all the time. And since you can't find locums anymore, coverage substitutes, and the walk-in clinics are all closed post-pandemic, you either have to stay or tell people to go to the emergency room. What we can do if there's over 100 of us is we can come and go as we please, and it just gets absorbed into the system so that people can be taken care of 7 days a week. There's 24-hour call. We have coverage. People can take vacation, and that only occurs with scale.
Yeah. And like, is it true that scale allows like at least the staff to find room to grow and career progress
Oh, yes.
and like
Yes.
specialize at being best in class in something? Like you mentioned, the
Yes.
superhuman to be your IT, your HR, your billing, and your receptionist now is like you can play to their people force.
Yes, yeah, exactly. Like, if you have a job where there's no career progression, you'll get people who cannot get career progression. They cannot move up, or you will have a lot of turnover. That's just the nature of that type of job. So with us, we're able to have great retention because we can have career progression. The bigger we get, the more roles we have, right? The more responsibility you have. So it's for us really nice because then you actually have a manager who has been a front desk secretary, right? A senior manager who has been a manager. So they've experienced all those roles. And then we can have people who, in our Great Place to Work survey, we saw that about 40% of people joined our company specifically for the opportunities for career progression. And that there's no other clinic group where you can do that. So we're able to have really great team members.
Other systems or practices that have proven to be especially effective as Terra Nova has scaled.
I've used a lot of technology and encouraged it really early. So, for example, you know, I call it TerraBot. We have a bot with, I've downloaded all the CMPA articles and the CSPC articles and all of the clinic policies, all of the electronic health record policies and training modules and everything you can think of that might even peripherally be related to medicine. It's all in there. And then people can ask it questions. We have a Discord group so that people can just also ask other human beings questions. We have every plugin available. Every time technology is legally available in Canada, we have it as soon as it's possible. I invest a lot into this, even if it's not even a clear economic benefit at first. I just believe that when people are happier, they do a better job. And people are happier when they do less grunt work.
Did you implement any like operational framework or management framework, like how to communicate the vision across 20 sites and to keep people connected and aligned toward the North Star? No, North Star, sorry.
We have a lot of meetings with managers, and then we sort of pass that information on. We're just building our clinician portal and our staff portal right now, so we can put all of these updates in. We like to have events, and I just encourage. We have end of day and beginning of day reports, so everybody can just report to us. It sounds a little bit corporate at this point, but I just tell everyone along the way, please reach out. You're valued. Your feedback is really, really valued. Here's my personal number, my personal email, and same for all the managers and the staff. So I think we try and do it that way by remaining very personable and just forcibly, I guess, keeping a culture where we spend a lot of time trying to receive feedback and work on it.
So what do you think is Terra Nova's biggest challenge today?
I think the biggest challenges today is that, you know, we've seen this hyperinflation post-pandemic, and then we have all these international wars and technological changes, patient expectations. Before, when a patient wanted to be seen, they just showed up. They came to the clinic. Now they want online booking. And if the online booking is broken for 30 minutes, they're very, very upset. And then they complain. Or they have online booking, but they want a phone and they don't want a voicemail to be given back to them. People, I think, are the patient population has changed. They have different, sometimes unrealistic expectations for the budgets that all clinicians have to run with. And then just rising costs. When I built my first clinic, the medical beds that we bought were $1,000. Now that same medical bed is $4,000. I'm not paid 4 times as much as I was back then. Yeah. So, all equipment is more expensive. Before, there were no technologies to pay for. You just had free paper, honestly. People, like drug companies, gave you paper. Now you have to pay for this technology and that technology, although it does save you time. Before, you didn't need that at all, right? So those are extra costs. Unlike any restaurant or store, which can raise prices if there's inflation, the government controls our prices. They've given us a pay raise recently in 2023, but it's not proportionate to the rising costs. That's why many clinics are not able to function anymore.
Yeah, and awesome. And this gives us a segue to LinkedIn post you highlighted that a report from the Vancouver Division of Family Practice stated that many clinics are operating at or below break even.
Correct.
So
yeah. So the
Vancouver learning and what's your take on this matter?
So this is what all clinic owners thought, but Vancouver Division wanted to show this. So what is the division of family practice? Each city has a division of family practice, and this division helps allocate resources for that city. So Vancouver, they hired a consulting company and asked clinics if they wanted to volunteer. So 15 clinics volunteered, and they gave up all their financial data anonymously not anonymously to the consulting company, but it was shared anonymously later. And they were able to see, the classic overhead splits would be 80-20, 75-25, and 70-30 with the larger portion going to the physician. And you see most new people coming to work in British Columbia when they want to be recruited, they want to pay 80-20 or 75-25. 70-30, they say, oh, that's so high. Who would work with you? We run at 70-30. We run a very high quality service. And that study showed that anything under 70-30 is at very high risk of going out of business. So like at 80-20, it's 50% chance of going out of business in the next few years. And at 75-25, you are 20% chance of going out of business in the next few years, with another 20% having only $10,000 buffer per doctor per year. So again, like if your toilet floods, it's over. Now you're out of business. You could just imagine the thinness of these margins. Fortunately for 70-30, in the report, they wrote it as profit. But I mean, I don't think there's any business in this world that wants to run on $0 extra per year and still feel comfortable that this is a proper business to be in. I hardly even use the word business at this point when you're talking about these kinds of numbers. This is essentially charity that clinicians are giving to society and subsidizing the costs in order to even stay open at this point.
And what's Terra Nova's top priority for the next 12, 18 months in this context?
My priority is to stay ahead of the costs by continuously doing good service, but continuing to grow. The only way is economies of scale at this point. So the bigger we get and the more efficient we become, we're doing a lot of efficiency work every month to just keep refining processes more and more. Just so that we can remain not only financially viable to even stay open. I want to be a really full service clinic. We have maternity, paternity leave on 70-30. We have extended medical dental coverage for everyone, including the clinicians. We have, again, all the technologies available. We have really high quality service. If people want something, we always listen to them and we try our best to work on it. That's very difficult to do with the budget we have, but we do it because we believe in our mission. So I would like to keep doing that and then just keep getting better.
Listen, I from the external world, I was able to notice the joy and happiness you're bringing to your team. I'm pretty sure happy staff means happy clinic, happy physicians, and happy patients. And hopefully you created the flywheel that allows you to keep growing there. We're cheering for you here. So
yeah, thank you.
Really well deserved. You're doing something amazing. And I want to ask you what you think about the longitudinal family practice payment model that was newly implemented in BC. We got a lot of great comment and positive vibes.
Mm-hmm.
Would like to know from your standpoint of view, where is it successful and where is it falling short?
So just like if you make a one-size-fits-all solution, it's going to just fall short in many aspects, okay? But if we look at the previous one-size-fits-all solution, which is the fee-for-service model, you would get paid something like $30 to $50 per patient. And the average family doctor would see a patient in 7.5 minutes. We have actually very good mortality and morbidity numbers, but you can just imagine. It's like a medical school exam every 7 minutes. Just go, 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 go. No niceties and just keep moving. But we did a lot of work and we did that. And that was good. You can imagine, though, that when you get paid per hour and you're encouraged to spend more time and to impanel patients, the number of patients you can impanel and the number of patients you can see goes down. I mean, that was sort of the purpose of the model, right? So you kind of get these conflicting reports saying, how come we have more doctors than before, but their efficiency is lower? I'm like, that was the basis of the new payment model, that we had to see, we could see less patients and spend more time with them, right? So if they are trying to, speed up the attachment of patients, I would have said the fee-for-service model would have been a faster way to do that. But of course, we had a lot of very, very unhappy doctors because nobody wants to work like that. Patients don't like to be seen in that. Nobody likes that. The other thing is, prior to the pandemic, there were a lot of walk-in clinics. And that meant that it was sort of an informal locum coverage for when people wanted to go away or the doctors weren't there, it was the weekend, and that kept people out of the emergency room. Now that you cannot do episodic care without being on the fee-for-service model, which nobody likes anymore because you get paid less for more work, they're de-incentivized from seeing patients who are not your patient, which means that there are no more walk-in clinics, which means that if your doctor is away, you have to go to the emergency room. So now the province has had to build urgent care centers across the province, which are very, very expensive, which they have to fund themselves, unlike the walk-in clinics, which were previously funded by the physicians. So I wouldn't really say that's working or not working, but it's definitely much more expensive for them. Much, much more expensive. And I feel like if they had just implemented some version of that into the payment model, then they wouldn't have had to do that. And it's the same with vaccines. At age 1, a child is supposed to have 4 vaccines. They pay you for 2 vaccines at a time maximum. So now doctors don't want to do vaccines. So then they have to build entire public health departments where they hire nurses who see patients every 30 minutes to 60 minutes to do the vaccines, whereas a doctor would have just done it during their appointment. So then that costs them more money too. Again, maybe that's okay. That's fine. But there's a lot of, funny contradictions there where they complain that doctors will do this or won't do that, but it's literally baked into the payment model that they gave us.
Yeah. And like, I don't want to make you repeat yourself, but what I understood also, the way you're compensating for that as an operator of clinic model is you do it on your dime. Like
I do it on my own dime, yes.
Yeah.
I pay for it. It costs me money and I lose money. I lose money on vaccines. I lose money on autoclaves. I lose money on being full service, on having urine drug screens and doing prenatal care. I lose money on all of it. It's okay because that's just my belief that it all comes out in the wash. I'm not going to penny pinch medical services for a few dollars here or there.
And how much?
But if you're on the financial brink, you will. Sorry.
Yeah, no, yeah. Like I get that. And leaders like you who operate in clinic, how often you need to have such discussion with authorities and doctors of BC and the health minister? How much this is part of your reality to stay connected and keep the other authorities also connected with what's happening on the ground?
Well, I do talk to the divisions of family practice quite frequently, the primary care networks. I do communicate with the health authorities and the Ministry of Health. I don't know how much it's particularly effective, but there are various programs, fundings, things like that, and I need to work with them quite a bit. I think that one good thing is that most everyone is pretty good-hearted and they have great intentions. I think one bad thing is, and you'll hear this in literally every industry I've ever heard, that the people who are the administrators are not the people who are the workers. So there's always a slight disconnect, asymmetrical understanding of what they believe should be done and what we believe should be done. And that's normal. And that's okay. That's just normal friction. So I do feel very grateful for all the people I've worked with in British Columbia, despite all sorts of friction. They might find that I'm giving them unnecessary friction too. But it's been a real work in progress, and I do have to also commend them for how many changes have occurred since 2020. It's a lot of change, like more than that they did for 10 years prior. So it's probably very difficult on them, and we should expect that during this difficult transition, there will be a lot of errors.
And well, listen, one of the reasons we put this podcast together is to be able to shed the light on what's happening in primary care and connecting people together and hopefully bridge some communication gaps and reality gaps between operators, physicians, and the authorities and the society. I'd like to switch gear and talk more about your leadership style, Dr. Wilson. Every leader faces tough choices. I feel like definitely in your case, cash flow is a reality, and
Yes.
retaining people and dealing with physician and aligning everybody. What core values guide your leadership decision when trade-offs are unavoidable?
I always like to think about what is right. I remember years ago, more than a decade ago, maybe 2 decades ago, I was applying for medical school, and we had these old paper sheets that we used to hand around with old medical school questions. And one of them is, what is integrity? And I always remember that question, what is integrity? And I think that it's taking the right path if it's even the more difficult one. And I always ask myself in every decision I make, is this showing integrity? So I told you before, in our previous conversations, but, I wanted to expand into underserved areas. And I feel that I really believe this as a family doctor. And maybe people in preventative care who aren't in preventative care won't see this, but I feel for every missed screening exam, there is a proportion of people that will have a negative outcome and or die, right? For every missed vaccine, there's someone who might get sick. For every missed diagnosis, there will be problems. So I am a true believer in primary care, a true believer. So when I see that there are hundreds of thousands of people who aren't getting the care, I feel so sad and so upset that I mortgaged on both my houses without even any financial plan to, my house and my mother's both house. Actually, she's been working with me since the beginning, to be able to fund further expansion into these areas. And even if I lose all that money in the future, if it doesn't work out, I will still feel at peace that at least I've done something good. So that's how I like to judge it. Now, ideally, I would not like to lose my home and my mother's home, but I would still prefer that, and she as well, than to have people suffer. So
Is it
that's where
true
my
that
belief
you had
is.
to mortgage your house to build Terra?
Yes. Yeah. To expand and to grow.
So I think integrity is not the only core values. I think compassion, I think definitely you and your team has compassion and empathy for what's happening in the healthcare, and your driving force. Um, so, Dr. Wilson, alongside everything you're building, you're also a mother of two children,
Yes.
and the youngest one, if I'm not mistaken, is 1 year old.
Yes.
How do you keep up with this pace and demand of it all?
I think that when you love something, it doesn't feel like work. People, maybe when they have kids, they'll know this. Like it's, if you're a child, I like to sleep with both my children now, that is safe. And they might wake me up 6, 10 times a night between the two of them kicking and, wanting to talk to me. But it's just a joy for me because I love them so much. And I feel like that with my work. I feel that, and maybe it's again that I'm a true believer that it has value, that it doesn't even feel like work. I've always called building Terra Nova and growing it my hobby.
So what a typical week looks like for you now? Like walk me from Monday, walk me from Sunday evening till Saturday evening, if you don't mind.
I like to keep my evenings for my family, so probably would start then Monday morning. So I wake up, I check all my emails. My whole life is in my emails, so I'm very strict with that. Get a few hundred emails a day. I just go through all of them the moment they come in, sort them, deal with them.
If you don't mind, what time you wake up?
I usually will wake up at, this is very bad. I usually wake up at 3 a.m. and sort all my emails. And then I will wake up at 6 a.m. and sort all my emails again. And then, get the kids ready. Then at 7 a.m., they're still getting ready. Then around 8, I'll go to work. I'll work. And then I will clean everything up. Then I will check on all my results. I still work as a doctor. I took some time off from my patients, but I have a very, very large patient panel, and I check a few hundred results a day. And whenever people go on vacation, I take their results. So it's just easier for me to do the results of everybody than to find someone else to do other people's results. So I've always done. So then I'll do that. I'll call a few patients, then I'll go back to my emails. I usually make a new program. I have lots and lots of ideas. So I write down all my ideas, and then I'm always implementing something, maybe 2 or 3 things at once. Then I interview a few clinicians. I've now recently just given that to my husband to interview people and bring them in. Usually we interview 3 to 6 people a day. And I work on, now I feel like I'm an immigration expert and licensing expert, bringing a lot of foreign clinicians in. So I spend quite a bit of time doing that. Then I talk to several team members, continue to answer my emails, call a few more patients. Then maybe I'll have a coffee. And yeah, I just continue this back and forth all day. Sometimes I drive around, look for I go visit a new clinic, or I visit a site. I talk to the staff. We have long staff meetings twice a week, maybe about 3 hours. And then usually I like to like find different things to train my staff in. So then I'll like do the course and think about the course and then try and implement it to them. I don't know, fix the website. I talk to the health authority a lot, the divisions of family practice. I do a lot of negotiation with them. I get into policy meetings with them. I juggle around a lot of contracts. I write a lot of contracts. And then I just sort of take it how it comes throughout the day.
What's your superpower? If you can call one superpower, what's your superpower, Dr. Wilson?
I'm amazing at sleeping. I can go to sleep anytime I could sleep for 20 hours if I was on a 20-hour flight. I could
Awesome.
nap, I could sleep anytime.
How do you protect your own mental and physical health? Like, I lead the company, and I always struggle between like finding time to do my gym and relax and vacate. How do you balance that? Sure.
I'm very lucky as a family doctor that I counsel people on a lot of things. And at some point, it's like physician heal thyself, like listen to your own advice. So I tell people like, okay, would you show up to work late because you had to do the dishes? No. So why would you go to sleep late? Because you had to do the dishes. Respect yourself and respect your time. So if you say you're done at 5 p.m., then you're done at 5 p.m. unless there's an actual emergency. And it should be a real emergency. So I create boundaries and I'm very strict with them. And I like to do them. I also love to read. So I find reading for me is my meditation, my good mental health. I dedicate a few days a week to spend time with friends, and I hold those as sacred as as a meeting with a mayor, or having a patient appointments. You have to respect yourself and your boundaries.
And if you don't mind me asking, what type of reading you do? Like, is it business? Is it lifestyle?
Well, I get into like trends, a lot of times I read business. Right now, and I know that this is a little bit geeky, I'm really into Russian literature. So I'm trying to read I've read all of Dostoevsky this year and, in the past 12 months, and all of Tolstoy. Now I'm getting into Chekhov and Pushkin. And then I read them over and over again. It's getting a little bit obsessive, but I just find it very soothing. They're the world's greatest psychologists. So you can find an example of everything you've ever experienced or everyone you've ever met in their novels.
Any book would you recommend our audience?
Oh, it just depends on what you like. I really think that for me, literature is the greatest art of all. So if there is any book that you like, it is just, for me, the most soothing thing to the soul just to read anything. So just pick up any book and read it, and you will feel happier and healthier.
You mentioned sleep, and you sleep very well. What keeps you up at night? Like, what is your biggest nightmare? What is the thing, your biggest challenge that keeps you awake at night?
I think, I can really bite off more than I can chew, right? So there's always this time period between when you're overly optimistic and you think you can do something, and then reality hits and you're like, oh, it's not as easy as I thought, which is literally every project I've ever done, right? And then there's a gap in time between that realization and when you figure out the solution or get to the solution. And that just is like a recurring problem. But we always get there. If you need to get something done because you put yourself in a bad situation, you will just get it done.
And what keeps you motivated on those difficult days?
I think, my family, my children, my friends, and I think really just the belief in what I'm doing. Like I really love my patients, and I feel all the time that I failed them because I could never do a good enough job, right? And I just feel like that for society too. Like no matter how much I do, it's never enough. And I feel like I just need to keep going, I guess. And that's what motivates me.
Awesome. So, what's your take on AI in medicine right now?
I think it's great. I mean, it depends on how you use it, but there are so many tasks that people don't like that a human being doesn't have to do. And if we can take away those tasks, we could probably have better retention, better happiness, better customer service, all of those things. when you talk about people asking ChatGPT about their symptoms, that's I think a different case. Then it's depending on the user. It's similar to when Google came out, right? And people would Google their symptoms. It's user dependent. Some people can use things responsibly and understand the risks, and some people cannot. When it comes to AI in medicine, I think it can be a great time saver. It needs to be validated, of course. We need to protect the data. It comes with its own challenge. Any type of workflow change is not easy, but I am a big believer in the potential for this to really save medicine, because we just cannot continue as we were before.
So is it a must-have or a nice-to-have?
I think it's a must-have.
And do you think it's gonna cut jobs? Like clinics and needs to embrace AI. I fully agree with you. And Jensen, the CEO of NVIDIA, said he doesn't believe that AI will cut jobs. He said, if you think AI would cut jobs, it's because you're lacking imagination. And I meet other leaders will say, well, it definitely is gonna reduce the workforce. What's your take on that?
My take is that there is unlimited work to do. There is so much work to be done that we cannot get it done. So if you add AI to take off some of that work, all that ends up happening is you just end up doing that other work that needs to be done. Let me give you an example. I have been in medicine since like 2008, right? Starting medical school. And in that time, do you know how many times I've heard the phrase, I just cannot get through to my doctor's office on the phone? I have tried to solve this problem in like every possible way. I have tried to have online booking, emails, voicemails, hire more staff, extended hours, all of these things. It just is, we just can't. And then when you see the Vancouver division study that everyone is operating on such low margins they might go out of business, that even hiring one more staff to answer the phone would actually drive them out of business. How can you think that adding, for example, as you mentioned, some EMR companies like Mile might be adding an AI receptionist? How can you imagine that that's cutting jobs? That job just wasn't being done, right? And I see this with patients. If you take care of your patients, right, and you have a wait list and it takes 2 weeks to see them, they'll bring you the most difficult problem. But if you have a good relationship with your patients and you have no wait time, they'll come in and ask you all sorts of questions like, oh, I had this rash for 3 years and I wasn't that worried, but I thought since you were here and I was here, I'd ask. There's always more work to be done. So I see that with AI. It will do work that people would have otherwise done, but I just think that there's just so much more work to do. I agree. People will just come up with more ideas on how to improve things.
And let's imagine you wake up tomorrow as a Minister of Health. What is the first and most important thing you would do?
I would clarify the statistics on what's actually happening. So, as an example, they make funding decisions in British Columbia based on something called the Healthcare Connect Registry, where they see how many people here have a family doctor and don't, by how many people are on this registry. But if you play a game and you walk down the street and you ask the average person, have you heard of the Healthcare Connect Registry? I have not yet come across one person who has said yes. If you are making your funding decisions based on a resource that the average person doesn't know about, then these are incomplete statistics. That's just one example. So I would spend my time trying to fix the statistical gaps, because if you don't know what's happening, how can you solve the problem?
100%. If you can't measure it, you can't improve it. So what do you think is the most pressing challenges facing primary care clinics in BC right now?
I mean, talking to other clinicians and other clinic owners right now, it's recruitment, retention, and cost. This is the big problem. And this is what caused mass closures during the pandemic, which we never recovered from. And if you ask most clinic owners, it's only getting worse.
And after you clarify those statistics, what would be the policy changes that would have the biggest positive impact on frontline physicians?
I think if somebody in the ministry knew the economic conditions that primary care and other clinics operate under, they could either help direct their funding towards improving that or coming up with things to help. Doctors are not business people. So if they are in a fragile business situation, they may not realize it and they may not know how to improve it. But a consultancy firm for the entire province may know how to do it, right? And then they could pass that information on and reduce the fragility. Every family doctor you've seen ever is funding their own clinic. And if these mini business owners don't know what they're doing and the situation is getting difficult and then they go out of business en masse, then there will be no more family doctors. I mean, that's the extreme case, but this is a situation that should be monitored, I believe, right? I'm struggling and I'm not like struggling, but it's not easy. It's not an easy business to be in. And every single doctor I have met has said, how are you doing it? And I told you this before, Elias, but I find that a very disturbing question, that they're wondering how you can be financially viable. Like they're curious and they're shocked. So if every doctor in the system is wondering how a person can be financially viable, that means we are in a very unhealthy state.
Yeah, being viable, being an exception, it means we are in trouble. Like definitely needs to solve that. So just to recap here, you really think that like we are at, like, I think the model everybody's agreeing is a lot better. The new billing model is a lot better than
Yes.
the one before. I think there is a gap, clarifying those gap, bringing the right statistics and doing surgical interventions on those areas will come very helpful. And it's about funding some other areas and equipping clinics with tools and managerial acumen to be able to kind of get into the profitable side of things in order to allow it to do more and more.
Yes, exactly. And if you don't feel comfortable giving doctors more money, thinking maybe they'll just take it home and buy a Ferrari, okay. Buy all clinics vaccine fridges. Buy all of them an autoclave. Give them free sutures. Give them gloves. It doesn't have to be monetary. Give them a business advisor to go through their accounting to make sure they don't go insolvent. There are lots of solutions that don't involve just handing over cash if that makes you uncomfortable.
And on the positive side, when you look to the future, what gives you hope for primary care in BC?
We just talk to so many people, so many clinic owners, doctors, and again, the Ministry of Health and the primary care networks and the health authorities. And I feel everybody is trying really hard. And maybe I'm just such a person that is a believer in humanity, but I think that if everybody has the right intentions, then we have a bright future.
Before we close, what do you hope physicians and healthcare leaders across Canada take away from this conversation?
I mean, I hope that what they can do is just hear another voice of somebody who's in the system. I feel that the voices on the ground often get lost, right? We don't make the news, maybe they come, if the news does come, they ask the same 10 doctors repeatedly and they ask them a very specific question about something they want to hear. I think that the average family doctor situation is a surprise to most of Canadians. And I think that putting clarity on that would help direct resources towards stabilizing the system.
Maybe visiting clinics more and spending time on the ground and speaking with multiple leaders and physicians will definitely help clarify the situation. Dr. Wilson, it was really insightful conversation. I think you were able to inspire us during this conversation, and I will ask you if you want to add anything else. Otherwise, I want to thank you so much for the time you gave us. You've been generous with your ideas, and I wish you all the best.
Well, I just want to thank you for doing this. I feel like you're also a big proponent of improving the state of medicine in Canada. So I think that we all just have to come together, do what we know how to, and work together with a positive attitude. And I think we're going to really see bright things in the future.
We share integrity and we share compassion for the care system and for the patients that deserve better. So once again,
Yes.
thank you so much. It was really a pleasure.
Yeah, my pleasure. Thank you. Take care. Bye.
You too.